Assalamu alaikum. Uh, Today we'll be talking about hepatic vein doppler. First of all, why hepatic vein? Why not IVC? The inferior vena cava is bigger than hepatic vein, and the reason is if we look to this video, the loop from actual patient or hospital, you see the IVC is horizontal while the hepatic vein is vertical. So the reason is we interrogate hepatic vein because the alignment. It is aligned very well with the ultrasound beam. This is the P from Philips. This is our probe at the subcostal view. So the reason for interrogation of hepatic vein and not the IVC because of the good alignment with the ultrasound beam. This is the reason. And if you can see here in the color doppler, you see again, you can see very well the color flow, and it is very well aligned with the hepatic vein. So this is the reason. And if we look to the hepatic veins, we have three main hepatic veins. We have right hepatic vein, middle hepatic vein, and left hepatic vein. And these are the ones, right, middle, and left. Which one we use for the alignment? Most of the time, we use the middle hepatic vein because, again, the alignment is better than the right and left hepatic veins. There are some facts we need to know about hepatic vein doppler. First of all, as we said before, in venous flow, it is continuous flow or wavy. During systole and diastole, it is continuous, while the arterial flow is pulsatile. During systole we have, during diastole you don't have. The second fact, the flow is phasic and bidirectional. So there are no valves at the mouth of the hepatic veins. So the flow is bidirectional, can go forward or antegrade and can go backward or reversal. And the third fact, it is predominantly antegrade or forward flow. You have a small, as we will see later on, have a small reversal or backward or retrograde. Mainly the flow in hepatic veins are forward towards the IVC and from there to the RA. The fourth fact, we have fluctuations in flow direction and velocity reflect changes in RA and RB pressure. Always, when we talk about hepatic vein flow, systole or diastole, always we refer to ventricular events to avoid confusion. So when we say S-wave systole, we mean the ventricular systole, and when we say diastole or D-wave, we mean the ventricular right ventricular diastole. So now let us talk about the normal hepatic vein doppler. First of all, we have antegrade waves and we have retrograde or backward waves. Let me maximize this one. Okay, so the first wave is the A wave. What is the mechanism of the first one, the A wave? So the A wave corresponds to atrial contraction. Okay, so the A wave corresponds to atrial contraction with the tricuspid valve open because, as we know, the A wave or the atria contracts at the end of diastole of ventricle. So immediately after P wave of the ECG, we have the A wave due to contraction of the atrium, right atrium. So with contraction, tricuspid valve open, the blood is propelled in two directions: antegrade towards the RV and retrograde towards the IVC and hepatic veins. Okay, so this is the A wave, which is the backward, and we have also forward. So during ventricular systole, the movement of the tricuspid valve annulus toward the cardiac apex creates a relative negative pressure in the atria. So the descent of the ventricular, the annulus, tricuspid valve annulus, as shown here. So we have two. First of all, the contraction and descent of the tricuspid valve annulus, because during systole, the contraction of the RV from the base to the apex. So the descent of the tricuspid valve annulus will create big negative pressure in RA, and this will lead to flow of the blood from the right atrium to the right ventricle and will give us S wave. So the mechanism of S wave, two mechanisms. Number one, in the contraction, and mainly more than that one is the descent of the tricuspid valve annulus towards the apex. This will create a negative pressure. Then we have the V wave, very small one, retrograde or reversal. The V wave corresponds to atrial overfilling. At this time, the tricuspid valve is closed, and at this time, the atria is being filled by blood from the systemic veins. So this is the atrial filling. The only time, it is usually very small. The only time you have big V wave when we have severe tricuspid regurgitation, as we see later on. And instead of the tricuspid valve being open or closed, it is open, and this will lead to reversal of flow to the right atrium and will give us big V wave. But usually the V wave normally is very small reversal. Okay? And then the last wave is the D wave, begins as the tricuspid valve opens. When tricuspid valve opens, and in this situation, the right atrium will be just works as conduit from systemic veins, will conduct the blood from the atrium to the ventricle. So D wave, it is forward wave. We will repeat this one in table. So we can, and we correspond it with the hemodynamic tracings and with the ECG. So it will be clear. So we said the S wave, this one, this is a most prominent wave. It is forward. It is antegrade. Okay, when this at early and mid systole. Okay, we said this is systolic wave of the ventricle when the tricuspid valve annulus descent. Okay, will create negative pressure and will make the blood flow from the right atrium to the right ventricle. So the S wave, it is below the baseline, so it is antegrade. It is forward flow, okay, and this is the mechanism of it, the descent of the tricuspid valve annulus, and it coincides with the X wave of the atrium, okay, because this is the relaxation of the atrium, during systole of the RV, okay. So the S wave coincides with the X wave of the RA deficit. Because this is because of atrial relaxation. So two mechanisms of S wave. Number one, atrial relaxation. This will create negative pressure, will let the blood flow from the hepatic veins and IVC to the right atrium. And the second mechanism, the big one, is the descent of the tricuspid valve. So two mechanisms of S wave. Then the V wave is backward flow or reversal due to the closure of the tricuspid valve flow and bulging of the tricuspid valve annulus into the RA. This will cause backward pressure and backward flow into the right atrium, and this is the reversal. Okay, it is during what? During end systole. Okay, end systole before just diastole. At the end systole, because of the bulging of the tricuspid valve annulus into the RA, this will cause a reversal, which is the V wave, small one usually. And then D wave, as we said, tricuspid valve opens, diastole, the diastole. Okay, this coincides with the Y descent of the RA, because this is the emptying of the RA, okay, because the tricuspid valve opens. This will lead to flow of the blood from right atrium to the right ventricle, and this will be forward flow. And usually the S wave is bigger than D wave. This is normal. And lastly, the A wave, as we said, at the end diastole, after P wave, it is backward flow, because when the atria contracts, it will push the blood forward, diastole, and at the same time will push the blood forward. A small amount of blood will be backward into the RA. So this is the the waves of the hepatic veins, ASVBA, and combined together with the RA tracings and ECG. Now we'll talk about the changes of hepatic vein during inspiration or respiration, respiratory phase. So, phase of inspiration and expiration. What will happen during inspiration? What will happen during expiration? So during inspiration, the interthoracic and intracardiac pressure will decrease here. I think maybe there is mistake here. So the interthoracic pressure will decrease. Okay, so the venous return will increase. Okay, and that is why the forward flow. Please correct this one. During inspiration, the interthoracic pressure will decrease, but the intracardiac pressure will increase. Okay, so no, sorry, the decrease. Okay, so this one is a mistake. I will correct it later on, but please correct it. So during inspiration, interthoracic and intracardiac pressure will decrease, and this will lead to flow of blood. Okay, so and here inspiration increase, the opposite. Okay, so this will be here and this will be here. Okay, let us correct this one. Okay, so and because the interthoracic pressure increase, the suction will increase, and the venous return will increase the right side, and this will lead to increase of S wave and D wave, the forward flow. The opposite is right during expiration. The interthoracic and intracardiac pressure increase, That is why the venous return will decrease. This will reduce the S and D wave. There are some technical tips we need to be aware. So in order to get a good Doppler, first of all, we need to ensure the optimal ECG tracing. Otherwise, we'll not know which way it's systole or diastole. So we have to get it. And then we choose subcostal view, of course. We do some counterclockwise rotation of the probe to get the mid-hepatic vein for a good alignment. Then you put color flow Doppler, ensure good alignment, optimize pulse wave Doppler. We need to make the sample volume size 2 millimeters, sample location 1 to 2 millimeters inside the hepatic vein, optimize gain and filter setting, reject and compress until you get good Doppler, and add the spirometer to see the changes during inspiration and expiration. And the speed should be between 25 to 50 to assess the effect of inspiration, or 50 to 100 to assess the waveforms. Now we come to the pathology. We know already the normal hepatic vein, how it looks, and now we see in some diseases what will happen. So this patient, as you see, there is clear failure of coaptation. Okay, and tethering of these two leaflets. Okay, and of course, this patient has open, wide open, very severe tricuspid regurgitation. It's one of our patients. Okay, and we see the color flow of the hepatic vein. This is the IVC, the hepatic vein. And if we freeze it and run it frame by frame, you will see very clear, first of all, in color wave, because I mean the flow, forward flow will be blue and backward flow will be red, because it will be towards. So away is blue, towards is red. So away, the blue is normal flow forward, but the red is abnormal flow. It is the backward flow due to tricuspid regurgitation. And the reason is in systole, instead of this valve being closed in systole, it is open for failure of coaptation, and you have the IVC here, hepatic vein here. So the blood will go back towards the hepatic vein, and you will see what will give us in Doppler. So in Doppler, with each cardiac cycle, first of all, we don't have forward flow, diminished or absent forward flow. Instead, we have very big V wave, systolic wave, backward to the hepatic vein. Okay. And you notice that it is with each systole, we have flow, but we don't have forward flow, and we have only forward flow during diastole, D wave. So absent S wave and very large V wave, systolic wave. And this will explain the pulsatile lever. With each cardiac cycle, you will palpate or feel the cardiac cycle. So the sign, Doppler sign in severe TR is large systolic V wave. In tricuspid stenosis, we have prolonged deceleration time of D wave, like in mitral stenosis, okay? By the way, D wave like E wave, like E mitral, okay, or E tricuspid, okay? So in tricuspid stenosis, we have delayed slope, okay, slow filling, because the filling is impaired because of stenosis. So you have prolonged deceleration time of D wave, reflects slow decay of pressure through the tricuspid valve during diastole. And we have, of course, prominent A wave, because our A pressure is very high. Okay? The atria contracts against stenosis valve, so it will give backward. Okay, cannot push forward. Forward is diminished, but backward in the when atrium contracts at the end of diastole after P wave, you have very large A wave. So the changes of Doppler, hepatic vein Doppler in tricuspid stenosis, we have very large A wave and slow deceleration time of D wave. Now we come to the constrictive pericarditis, and I will go to this slide first. And we explained this one already when we talk about pericardial diseases and constrictive pericarditis. We have during inspiration, the venous return will increase. The heart cannot go laterally because of constriction. The septum will go towards the left side. Okay? And at the same time, reduce flow from the pulmonary vein. So this will decrease the preload in the LV. So during inspiration, we have the septum goes towards the left ventricle, and that is why increase forward flow during inspiration. S and D, we'll see it in hepatic vein. So from the hepatic vein, here we have increased flow during systole and especially diastole, okay? Diastole, we have increased flow, okay? And the reversal is very small. Let us see what happens during the expiration. During expiration, we have interthoracic pressure high. The flow from pulmonary vein is high, as you see here, increase. This is a forward flow, the D from pulmonary veins increase. And this will push the blood towards RV because also the venous return during this one is. So when the septum push the blood from the RV to the RA to the hepatic to the IVC and hepatic vein, this is a time we'll have reversal flow, very reversal flow during expiration and expiration, and this is the reason. The septum will push the blood from the RV to RA hepatic vein and IVC. So the cardinal sign of constriction in hepatic vein, we have increased forward flow during inspiration and reversal flow during expiration. And this is the explanation. So we have exaggerated interdependence between LV and RV due to non-compliant pericardium, augmented S and D waves in inspiration. As we said, this is an inspiration up, expiration down, inspiration up, expiration down. So we have exaggerated flow, forward flow in inspiration, and during expiration we have reversal flow, prominent reversal flow and diminished forward flow. You see here each respiratory cycle, not each cardiac cycle, but each respiratory cycle, here, here, and here. Okay? With inspiration we have increased forward flow. With expiration, we have diminished forward flow and reversal of the diastolic reversal and expiration. So diastolic reversal at the end expiration. This is the mechanism. Explain this one. So, and this is the one, the reversal here, the purple color. Restrictive cardiomyopathy, we have increased stiffness of the RV and LV, increased RV filling, pressure due to non-compliant RV, prominent diastolic flow reversal, but during inspiration. Here, during inspiration. In cardiac tamponade, what will happen? Hemodynamic abnormalities are similar to constrictive pericarditis. The main difference is the failure of early diastolic filling in tamponade. In tamponade, we don't have absent filling, okay, because the heart is compressed from outside, the RA, RV all are compressed, so the early filling is reduced here or diminished, and we have reversal flow during inspiration. This is the main reason. In elevated RV and diastolic pressure or pulmonary hypertension, we have again prominent A waves. In RV systolic dysfunction, we have attenuated S wave, longitudinal function of the RV. Reduction in RV systolic function causes blunting of the S wave, a little bit blunting compared to the D. نحن قلنا ال S more than bigger than D, but in dysfunction, RV failure or RV dysfunction, the D is bigger than S. In atrial fibrillation, we don't have A waves, absent A wave, and diminished or blunting systolic V wave. In AV dissociation or Canon waves in JVB, we have occasional very high A wave. When we have this one, when the right atrium contracts against closed, coincides with the systole. Both of them are systole. The right atrium systole and right ventricular systole. And in right ventricular systole, the tricuspid valve closed. So when the atrium contracts against closed tricuspid valve, this is the time you'll have very high backward A wave, Canon waves, from time to time. In pulmonary hypertension, we have very prominent A wave because we have RVH, right ventricular hypertrophy, and the right atrium contracts against resistance, high resistance, and we have prominent A wave, absent D wave, and S wave is normal. So this is all about hepatic vein doppler. Thank you.